All right, I am back. So heart attack, yes, I've already covered this slide, so let's move forward. Heart failure. Right now, at this stage, we should know very well that when we suspect that our patient is having a heart attack, there are 3 complications that the patient can get from that, right? 1, patient can go into cardiac arrest within 2 hours. 2, patient can develop heart failure, which can be either right dominant or left dominant, right? And the patient can develop cardiogenic shock. So heart failure. The signs and symptoms will differ depending on whether the right or left side of the heart is not functioning correctly. Right side heart failure occurs when fluid backs up into the body. So you're looking for jugular vein distension, ascites, that's fluid in the abdominal area, peripheral edema, and enlarged liver, right? Right-sided heart failure is often caused by left-side heart failure. So it is common to see signs of both, right? With left-sided heart failure, fluid backs up into the lungs. It causes a condition called pulmonary edema and shortness of breath. The patient will have severe shortness of breath and hypoxia with crackles in the lungs. These are things that we should be very familiar with at this stage. All right, now paroxysmal nocturnal dyspnea, right? So it's a sudden onset of difficulty breathing at night, characterized by a sudden attack of respiratory distress that wakes the person when he or she is reclining. Caused by fluid accumulation in the lungs, patient reports coughing, feeling suffocated, and cold sweats. You will notice tachycardia. If you suspect congestive heart failure, ask, do you sleep sitting up, right? So that's a good question to ask. Also find out if the patient has to sleep with pillows under the head and how many pillows. The more pillows they need, the more severe the condition is. All right, now stroke. Leading cause of death in older people, preventable risk factors, smoking, hypertension, diabetes, atrial fibrillation, obesity, and sedentary lifestyle. Uncontrollable factors, age, race, and gender. Signs and symptoms: acute altered level of consciousness, numbness, weakness, or paralysis on one side of the body. They can have issues with slurred speech, difficulty speaking, visual disturbances, headache and dizziness, incontinence, and seizure. All right, now your stroke is classified as either hemorrhagic or ischemic stroke. Hemorrhagic strokes are less common and more likely to be fatal. Broken blood vessels cause bleeding into the brain. Ischemic strokes occur when a blood clot blocks the flow of blood to a portion of the brain. The treatment goal is to salvage as much of the surrounding brain as possible, so time is important. If the symptoms occurred within the past few hours, the patient will be a candidate for stroke center therapy. Time is important to a stroke patient's management. Transient ischemic attack can present with the same signs and symptoms of a stroke, but they subside within 24 hours. All right, now changes in the nervous system. Changing in thinking, speed, memory, and posture stability are the most common findings. The brain decrease in weight and volume, so there's more space inside of the skull. So if they fall, they're at risk for subdural hematomas. There is 5 to 50% loss of neurons in older people. The performance of most of the sense organs decline with increasing age. Now, visual acuity, depth perception, and ability to accommodate light change with age. Cataracts interfere with the vision, decreased tear production leads to dry eyes. Inability to differentiate colors, decreased night vision, inability to see up close, presbyopia. Other diseases, glaucoma, which is pressure building up in the eye, macular degeneration, retinal detachment. And if the retina detached, they can't see, right? Because that's basically the link, the important link between the eye and the brain. So retinal detachment will lead to loss of vision. Hearing. Hearing problems cause changes in the inner ear, making hearing high-frequency sounds difficult. Problems with balance make falls more likely. Presbycusis is gradual hearing loss. Heredity and long-term exposure to loud noises are the main factors. All right, taste. Decrease in the number of taste buds. Negative result is because the taste bud decreases, the food doesn't taste the same, so they don't eat much. And that can lead to weight loss, malnutrition, and complaints of fatigue. Touch. There is decreased sense of touch and pain perception from the loss of the end nerve fibers. An older person may be injured and not know that they are injured because of decreased sensation of hot and cold. All right, now dementia, which is chronic decline of brain function. That's basically what dementia is. So it's the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. Chronic, generally irreversible condition that causes a progressive loss of cognitive abilities, psychomotor skills, and social skills. Dementia is the result of many neurologic diseases and may be caused by Alzheimer, which is the #1 cause, right? Parkinson's disease is also another cause, and Parkinson is when the substantia nigra in the brain, that's the area that produces dopamine, is damaged. And dopamine play an important part or has a role in how muscles coordinate movement, right? So these patients will have issue with muscle coordination. That's Parkinson's disease. Cerebrovascular accidents, genetic factors. Now, dementia. On assessment, patient may have short and long-term memory loss, have a decreased attention span, be unable to perform daily routines, show a decreased ability to communicate, appear confused or angry, have impaired judgment, be unable to vocalize pain. Now, delirium is the opposite of dementia. So dementia is chronic, delirium is sudden. There is sudden decline in the brain function, right? There's a sudden change in the mental status or cognitive process or the brain function, sudden, acute, marked by inability to focus, think logically, and maintain attention. It affects 15 to 50% of hospitalized people aged 70 years or older. Acute anxiety may be present. Delirium. generally the result of reversible physical ailments such as tumors, fever, or metabolic causes. In the history, look for withdrawal from alcohol or sedatives, medical conditions, psychiatric disorders such as depression, malnutrition or vitamin deficiencies, environmental emergencies. Now, assess and manage a patient for hypoxia, hypovolemia, hypoglycemia, hypothermia. You may see changes in circulation, breath, sounds, motor function, and pupillary response. Right? So when you suspect delirium, look for things that can be dealt with quickly. It could be that there is hypoxia, hypovolemia, hypoglycemia, hypothermia, and if you're able to fix that problem, then the delirium will go away, right? So sometimes you just need to treat the cause. All right, syncope. Assume this is life-threatening until proven otherwise in your geriatric population, often caused by an interruption of blood flow to the brain. Neuropathy, disorder of the nerves of the peripheral nervous system, function and structure of the peripheral motor, sensory, and autonomic neurons are impaired. Some symptoms depend on which nerves are affected and where they are located, right? So it can affect the motor nerves, it can affect the sensory nerves. Motor nerves, they will have muscle weakness, cramps, spasms, loss of balance, loss of coordination. If it's the sensory nerves, they will have tingling, numbness, itching, pain, burning, right? They will have also extreme sensitivity in the extremities to touch. That's sensory, right? That would be sensory. And then if it's the autonomic nerves, you will see changes in blood pressure and heart rate, constipation, bladder, and sexual dysfunction. All right, now changes in the gastrointestinal system. There is reduction in volume of saliva, dental loss. Gastric secretions are reduced, changes in gastric motility occur, incidence of certain disease involving bowel increases. Blood flow to the liver will decline at this stage. Issues with dental problems, decrease in saliva and sense of taste, that will affect how they eat. Poor muscle tone or sphincter between the esophagus and mouth, they'll have issues with digestion. Decrease in hydrochloric acid, alteration in the absorption of nutrients, weakening of rectal sphincter. All right, now GI bleeding can be caused by inflammation, infection, or obstruction of the upper or lower GI tract. Look for hematemesis, right? Bleeding that travels through the lower digestive tract usually manifests as melena. That's digestive blood. Red blood usually means a local source of bleeding that's linked to hemorrhoids. A patient with GI bleeding may experience weakness, dizziness, or syncope. Especially the syncope will come if they have to strain to pass their feces or have their bowel movement, right? All right, specific GI problems in older patients include diverticulitis, bleeding in the upper and lower GI system, peptic ulcer disease, gallbladder disease, bowel obstruction. When assessing patients, ask about NSAID and alcohol use. Orthostatic vital signs can help determine if a patient is hypovolemic. So if it's with protocol, you perform your orthostatic vital signs. Blood pressure and pulse rates are obtained with the patient lying, sitting, and standing, right? Note any drop in blood pressure, an increase in heart rate that occurs as the patient moves to an upright position. So that would be an indication of low fluid volume inside the patient. Acute abdomen, non-gastrointestinal complaints. Extremely difficult to assess in a pre-hospital setting. Most serious threat from abdominal complaints is blood loss. The AAA is one of the most rapidly fatal conditions. The walls of the aorta weaken and the blood leaks into layers of the vessel. If enough blood is lost, then the patient will most definitely go into shock, and this can lead to death very quickly. Yes, Ms. Nesbitt.
Sir, the AAA, is it the descending aorta that it normally occurs in, like one
Yeah,
aorta? Okay.
it would be the descending aorta, the one that goes down into the abdominal area, the portion that goes down into the abdominal area, I should say. All right, now age for the renal system, changes in the renal system. Age brings changes in the kidneys. So reduction in renal function, reduction in renal blood flow, tubule degeneration. And you know, so once the kidneys is affected, this will affect their abilities to remove waste from the body, right? So decrease for changes in the genital urinary system, decreased bladder capacity, decline in sphincter muscle control, decline in voiding senses, increase in nocturnal voiding, benign prostatic hypertrophy. So the prostate enlarges, especially in your geriatric patients when they get close to 60. That's a problem, right? It's common in that population, and that can interfere with their ability to pass urine, right? It can swell up the ureters and they're not able to pass any urine, and it causes severe abdominal pain, and they only can relieve the pressure by passing a urine catheter in the emergency setting. They will eventually require surgery at some point, or they'll put them on medication. Depends on the assessment of the doctor at that point. Now, incontinence is not a normal part of aging and can lead to skin irritation. So this is loss of the bladder control and loss of control at the rectum as well, right? Can lead to irritation of the skin breakdown, and urinary tract infection. Stress incontinence occurs during activities such as coughing, laughing, sneezing, lifting, and exercising. Urge incontinence is triggered by hot or cold fluids, running water, or thinking about going to the bathroom. Ouch. Yes, Miss Johnson.
So what you say, incontinence is not a normal part of aging, or it is?
It is not a normal part of aging. So if you observe that it is happening, something is wrong. Get that?
Okay, sir. Yes, sir.
All right, now the opposite of incontinence is urinary retention or difficulty urinating. In men, enlargement of the prostate can place pressure on the urethra, making voiding difficult. Bladder and urinary tract infection can also cause inflammation. In severe cases of urinary retention, patients may experience renal failure, right? All right, now changes in the endocrine system. There is reduction in thyroid hormone thyroxine. Signs and symptoms include the heart rate slows down, fatigue, dry skin, and hair, cold intolerance, weight gain. Yes, Miss Nesbitt.
Sir, the slide before, sir, about the genitourinary system, sir. I didn't hear a mention made about, especially the females, where you have the vaginal prolapse. Isn't that specific to the elderly
That's
population?
not something for EMTs to consider.
Oh,
Not
but
in this spectrum.
like we wouldn't be called to an area, like have a patient and can recognize the symptoms, no?
If they, that's not something for you to be familiar with. That's what I'm saying. If you're called to a situation like that, there's nothing you can do outside of ABCs and transport. So that's not required information for this level of providers. Remember, EMS system have different levels, right? So you have a limited scope of practice and knowledge. And based on your assessment, you will know when ALS is needed. You will know when it is outside the scope of practice. Depending on your location, all you do is you focus on your ABCs, but that's not something for an EMT to deal with. All right, now other endocrine changes include an increase in the secretion of antidiuretic hormones causing fluid imbalance, right? Hyperglycemia, increase in the levels of norepinephrine, possibly having a harmful effect on the cardiovascular system. And remember, norepinephrine will affect the blood vessels directly. Now, hypersmaller hyperglycemic non-ketotic syndrome is a type 2 diabetic complication in older people. So this is a patient that gets the severe dehydration, right? Severe dehydration. That's basically what all of that long words mean. That's what you're looking for. Signs of severe dehydration. On assessment, you may see warm, flushed skin, poor skin turgor, pale, dry oral mucosa, furrowed tongue, signs of shock. Are you able to hear me? Because my signal just went down a bit. You still hearing me clearly?
Yes, sir.
Yes,
Okay.
sir.
All right. Now, changes in the endocrine system. Assessment of the patient should include obtaining blood pressure, distal pulses, auscultation of breath sounds, temperature. Assessment of blood glucose level if permitted by local protocol. All right, now changes in the immune system. Infections are commonly seen in older people because of their increased risk, less ability to fight infection, anorexia, fatigue, weight loss, falls, or changes in mental status may be the primary symptoms. They can have pneumonia. UTIs are common in patients who are bedridden, especially in the nursing care homes in Jamaica. Signs and symptoms may be decreased because of sensation, lack of awareness, or fear of being hospitalized. Let's look at changes in the musculoskeletal system. So there is decrease in bone mass and bone density, right? Especially in postmenopausal women. So their bones become weaker, decrease in mass, becomes more brittle and tend to break more easily. The joints lose their flexibility, so the joints become more stiff and less flexible. A decrease in the amount of muscle mass often results in less strength. Changes in physical abilities can affect older adults' confidence in mobility. Right? Muscle fibers become smaller and fewer, motor neurons decrease in number, strength declines, Ligaments and cartilage of the joints lose their elasticity. Cartilage goes through degenerative changes, and this will lead to your arthritis issues. Osteoporosis is characterized by a decrease in bone mass, reduction in bone strength, and greater susceptibility to fracture is what it puts the patient at risk for. The extent of bone loss depends on genetics, body weight, smoking, alcohol consumption, level of activity, and death. Osteoarthritis is progressive disease of the joints that destroys cartilage and promotes the formation of bone spurs and leads to joint stiffness. Results from wear and tear. Affects joints in the hands, knees, hips, and spine. Changes in the skin. Proteins that make the skin pliable decline with age. Layer of fat under the skin becomes thinner. So they're gonna have issues with temperature regulation, right? Their skin is easily broken, so that put them at risk for developing wounds or infections. Bruising becomes more common. Sweat glands do not respond readily to heat. Pressure ulcers become a problem, sometimes referred to as bed sores or decubitus ulcers. The pressure from the weight of the body cuts off the blood flow to the area of the skin. With no blood flow, a sore develops, and that's why at this stage we try not to put them on a spine board, right? The vacuum mattress is preferred, and if you're going to put them on the spine board, you definitely need to put some padding, right? Like a blanket, maybe 2 blankets on the board before you log roll them. Your skin will break down very easily. Sometime within 30 minutes, they start to show signs of that. All right, now stages of ulcer development. Stage 1, non-blanching redness with damage under the skin. And think about the stages of ulcer development as similar to the depths of burns. It's similar, very similar, right? So stage 1, non-blanching redness with damage under the skin. Stage 2, blisters or ulcers that can affect the dermis and epidermis. Stage 3, the invasion of the fat layer through the fascia, and stage 4 is the bone. So consider the same depths that you would consider for burns. The patient can have that in an ulcer of the skin. Similar depth. All right, now toxicology. Older people are more susceptible to toxicity because of the kidney not working properly, altered gastrointestinal absorption, and of course, the dear liver not functioning effectively. The liver is a biochemist. Kidneys undergo many changes with age. Decreased liver function makes it harder for the liver to detoxify and eliminate medications and alcohol. Typical OTC medications can have negative effects when mixed with each other or with herbal substance, alcohol, and prescriptive medication or prescription medication. They are polypharmacy, right? Patients, so they have multiple medications. Don't write a bag of medication in your report, right? Write down the name of the medications. So polypharmacy refers to the use of multiple prescription medications by one patient. Negative effects can include overdosing and negative medication interaction. Medication non-compliance occurs due to financial challenges, inability to open containers, impaired cognitive vision, and hearing ability. Yes, Ms. Nesbitt.
Sure, in Jamaica, with the elderly population, because normally when they go to the pharmacies or even to private pharmacies, sir, they
Mm-hmm.
get medications that bear different names because we have so many different generics in Jamaica.
Yeah.
So we realize that they are taking like probably enalapril in two different brands. So that is what happens sometimes when they don't know because the tablets may look different and it may bear a different brand name. So that's the problem that we have in Jamaica.
Okay. Noted. Right now, depression. Depression is not a part of normal aging, but a medical disease. Treatable with medication and therapy. If depression goes unrecognized or untreated, it is associated with a higher suicide rate in the geriatric population, right? So it's actually higher in this population. Risk factors include history of depression, chronic disease, and loss. The following conditions contribute to the onset of significant depression: substance abuse, isolation, prescription medication use, chronic medical conditions. Older men have the highest suicide rate of any age group in the United States. Older persons choose more lethal means than the younger victims, generally have diminished recuperative capacity to survive any attempt. So because of the decline in their body systems, if the attempt was not successful, sometimes based on the decline, we're not able to get them back to good health, right? Even with our best efforts. Common predisposing events and conditions include the death of a loved one, physical illness, depression, and hopelessness, alcohol abuse, alcohol dependence, loss of meaningful life roles. All of these can lead to suicidal thoughts and suicidal attempts in the geriatric population. When assessing a patient who is displaying signs of depression, it is appropriate to ask if he or she is considering suicide. If the answer is yes, the next question should be, do you have a plan? Include this information in your report. All right, now focus a little bit on what is different in this population assessment. So we're going to be looking at the GEMS diamond, right? Now at this point, we will pause and take a 10-minute break, and we resume after the 10-minute break.